oftentimes is me trying to get them to a better and healthier place in life. For example, I saw a guy today. His hip was terrible. His BMI was 50 or 51. He had gained like 60 pounds in the past year. My approach to him, because he has really become deconditioned, he's doing a lot less. He was there with his daughter. He has grandkids. You'd say that this isn't just for you to get your hip replaced. This is for you to get to a better point in your life so you can enjoy the things that are meaningful and impactful and bring you joy in life without complications. So it's a pathway for them, because the hips are definitely a big part of it, or the knee in other cases, but it's not the only part, because there's a number of studies showing now. And again, there's good longitudinal data, the most recent out of Mayo Clinic again. People do not lose weight after a joint replacement on average. There's exceptions to every rule. I go over that data and I say, hey, if you just say, I need to get my knee replaced so I can go walk and lose weight. There's exceptions to every rule, but on average, that doesn't happen. So my philosophy, and this is where I've achieved a lot of success, is you start it on the front end. You get on their side, you ally with them. You need to be seen not as a barrier to your patient. You need to be seen as an ally. You work with them. You get them on the program. They're getting healthier. You don't force them to get their BMI down to 30, because that's simply cruel. Wherever your kind of cutoff is, you try to get close to there. And then you get them through surgery with them knowing they're at increased risk anyway. And then they carry it on the back end. And that's going to give them their best chance of success to getting to a better them for the rest of their life, because I am replacing their hip or their knee to hopefully last the rest of their life.